Early onset bipolar disorder is thought to be a subtype of late onset bipolar disorder. When we look at early onset, we see that there is a history in the family of bipolar disorders, and this shows us that it has some genetic predisposition. In a meta-analysis, when we look at the family members, there's a higher ratio in the family. In a 10-year follow-up, early onset bipolar suffering parents will have a larger possibility of having children suffering the same. There are two main genetic research methods: linkage analysis, candidate gene association studies, genome-wide association studies, and copy number variants. When we look at linkage studies, linkage analysis aims to implicate chromosomal regions that harbor variants with large phenotypic effects. Few linkage studies have been conducted on early onset BD. We also know that regions 12P, 14Q, and 15Q had minor association with age of onset. Chromosomes 18, 21, 22, and 19 were found to be associated with early age onset of bipolar disorder. Also, in another study was found there was 3 associations in nerve phenotype, early onset to PD, early onset of PD. These regions have not been replicated by other candidate gene or GWAS. When we look at the linkage studies for adults, similar outcome have been received, and this means that overall in the society, linkage studies, frequent findings point out to not variants at a high scale, but small variants with low efficacy. When we look at the candidate genes, we see serotonin transporter and receptor genes. Serotonin transporter returns serotonin from the synapse to the presynaptic neuron. Serotonin transporter gene is SLC64A, is located on chromosome 17, and the incision polyformer can cause short or long alleles and is associated with bipolar disorder. Studies on serotonin transporter gene have inconsistent output. There is no clear conformity as to whether relationship. Some studies point out to such association, whereas in some studies there is no such findings, so an inconsistent picture overall. When we look at other serotonin-related genes, we see that serotonin 2C receptor gene is associated with early onset BD. In another study, this wasn't replicated. Serotonin 1A receptor association was not found. H1 TRIA and BD, early onset BD association was established. When we look at dopamine receptor genes, we see that NIC could not find an association between age of onset in BD and 3-DRD1 polymorphons. In another study, there was an association, an identified association between the two. When we look at catecholotransference gene, it's actually very frequently studied gene. It's located on chromosome 22q11.2, involved in the catabolism of catecholamines. The Valmet polymorphism has been the primary subject of gene dissociation studies, and MET allele is associated with 3 to 4-fold lower COMT activity, resulting in increased synaptic dopamine. The Candy studies on COMT has identified no association between the two. When we look at BDNF, brain-derived neurotropic factor, we see that it regulates neuronal survival, differentiation, maintenance, synaptic plasticity, and axon growth. Inversely correlated to the severity of panic and depressive symptoms and involved in lithium response. In a study, we see identified linkage, disequilibrium of the BDNF polymorphism in children with a prepubertal and early adolescent BD. However, this finding has not been replicated in later studies. Studies on BDNF have not been convincing due to small size of the samples, so it's not been convincing. Circadian rhythm and clock genes. Glycogen synthase kinase 3 involved in the regulation of transcription factors and in the biological clock as well. The outcomes have not been replicated. When we look at the period 3 gene, it's related to circadian rhythm. The 17280 polymorphism was found to be associated with age of onset in BD patients. Apart from these, of course, there are other genes studied as well, and overall, in general, they were studied in one single research, and the outcome needs to be assessed very carefully. There is also GWAS, as we have said. They enable the detection of common SNPs, typically in 5% of the population across the vast majority of the genome. A small number of GWAS conducted in early onset BD failed to find any SNPs, so there is no such meaningful polymorphism detection. Neuroimaging studies. They are classified in 3 groups: anatomic MRI, MR spectroscopy, and functional MRI. They have certain advantages. They show the duration of the illness. They show in MR spectroscopy, we look at the neurochemical structure of the brain, and in functional MRI, we look at the blood circulation by way of oxygenization of the brain and the hemodynamic structures. Early onset BD can be an area where neuroimaging can be quite advantageous because of the short duration of the illness, short duration of the exposure to treatment, smaller number of mood episodes, and absence of substance use. So it's more cleaner and easier work area. When we look at the structural magnetic resonance studies, evaluates the sizes of specific regions of interest, voxel-based morphometry, VBM studies, an automated MRI analysis technique that examines the entire brain and allows for detection of regional differences in size between groups. This is a more advanced computer system which allows for the examination of the entire brain to take place rather than a small section, and it allows for detection of regional differences in size between groups. When we look at DTI, they measure the diffusion of water into tissue and provide information about the integrity of cerebral white matter and neuronal pathways. Decreased fractional anisotropy value indicate more random water diffusion and suggest less intact white matter tracks. They move in both ways, and these two-directional movement point out to an axonal dysfunctionality. DTI studies, they measure the diffusion of water into tissue, and the higher the number, of course, the higher the deformity level, structural deformity level. When we look at the structural studies, we see particularly similar to adult bipolar diseases, white matter disorders. This is the most frequent finding. Apart from that, total brain volume, hippocampus volume are lower. Amygdala volume particularly can be lower. And that's the most repetitive structural MRI finding. This is quite the opposite of adult MRI finding. In gray matter, there is a reduction. That's another finding. There is a change in pituitary. There is no change in pituitary volume. Superior temporal villus white matter is reduced. Temporal gyrus is important. Therefore, for bipolar adolescents and children have problems with social communication and establishing friendships. When we look at thalamus, we see findings are inconsistent, but there is no meaningful change. When we look at the putamen size, it's higher than average. When we look at the hippocampus, for girls only, there is a change, a downward change. For boys, overall, there is no significant difference. Also, when we look at the subgenual prefrontal cortex, there is no recorded changes of size. When we look at the sensor imaging studies, particularly for internal capsule on the anterior leg, there is lower fractional angiotrophy. On the right anterior cingulate, fractional angiotrophy is lower as per some studies. Corpus callosum's front half shows lower levels, and this axial organization is deformed in all of these variables. And when the details are assessed on the left side, myelin damage can be seen. Anterior coroneata aziotrophy is elevated. On the right orbital frontal lobe, functional aziotrophy is elevated. At the same time, on the right and left subgenual area, the coefficient is higher, which is directly related to the axonal damage.
Çalışmalara
When we consider the studies and phonics in the posterior cingulate gyrus and also post scoliosis from the phonics scantalopasis, fibers, we see that there is a decrease in the presupplemental motor area, dorsolateral prefrontal cortex, gray matter controls actually decrease compared to healthy results, and we see that gray matter increases in bipolar disorder cases. In a study conducted in our country, hippocampal volumes in the treated cases increased compared to non-treated ones. So the studies show that prefrontal cortex presents some structural changes in limbic system, and in MR spectroscopy studies, metabolites are taken into account. Neurotranscranial, phosphocreatine, glutamate, and aspartate are the ones that on which research are conducted. and there is increased elevated melatonin levels. Actually, phosphorus secretion causes a dysfunction, and aspartate actually is studied more and more commonly. And the high concentrations show for neuronal integrity. It's important for the neuronal integrity. Actually, in a nutshell, studies show that in basal ganglions in cerebellum and frontal cord, the secondary signalization in neuronal integrity and in neurotransmitter level, there are some abnormalities. Spectroscopy showed us, and in a study research conducted, we see prefrontal cortex and aspartate levels decreased, and there are maybe this is the findings that we need to remember in prefrontal cortex study, and aspartate decreases. When we consider fMRI studies in hypothalamus in bipolar disorder, neuronal activity is elevated. In bipolar disorder, compared to healthy cases, in a task, the neutral phases are more enemy-like, and they give a fearful reaction, and in this enemy-like perceptions left amygdala and prefrontal cortex, there is a higher activation. Again, when there is a fearful reaction, left amygdala and bilateral nucleus, there is a higher activity. And in another task assignment, regarding response and response inhibition, dorsolateral prefrontal cortex, there is a primary motor complex activity is increased. Regarding negative effects compared to the natural situation, anterior cingulate cortex and the left amygdala shows more activation, and the dorsal prefrontal cortex there is less activation. Actually, we can make a summary of this as the following. In bipolar cases, towards negative emotions, there is an increased amygdala response, and vis-a-vis that prefrontal cortex regulatory function is decreased. And amygdala hippocampal activation increased in some studies to show. This is all from my side. Thank you.